Hola a todos, muchas gracias por estar aquí esta mañana. Estamos en el auditorio Jesús Cumate del Hospital Infantil de México, Federico Gómez. Yo soy el doctor Salvador Villalpando y tengo el honor de hacer esta presentación a nombre del Departamento de Gastroenterología y Nutrición de nuestro hospital, de la Dirección de Enseñanza, Educación del hospital. Tenemos el honor de contar con la presencia de una gran invitada que el día de hoy nos ha acompañado a lo largo de a conocer las instalaciones, pero a compartirnos muchos de sus conocimientos y sus experiencias en el área de la rehabilitación intestinal. Ella es la doctora Shweta Namjoshi. Así se dice, aunque se escribe en español se podría leer diferente. Y ella nos acompaña de la Universidad de Stanford, en California. Ella es la directora médica de la Unidad de Rehabilitación Intestinal y Trasplantes de Stanford. Y como nuestra clínica de rehabilitación intestinal acá también tiene mucho interés de seguir aprendiendo y participando en estas actividades, pues con muchísimo gusto y con mucho agradecimiento y con mucha gratitud recibimos a la doctora Namjoshi para que nos platique cuál es la experiencia de ellos, cómo es el protocolo de ellos en rehabilitación intestinal. Adelante. La conferencia va a ser en inglés y seguramente podemos ponerle el traductor automático en la transmisión. Muchas gracias a todos por estar ahí en sus casas y cualquier pregunta, si la quieren hacer directamente en el link, y aquí pues será a micrófono abierto. Adelante, doctora Namjoshi.
Muchísimas gracias. Muchísimas gracias para todos, para invitarme aquí y también para su paciencia con mi español, porque no hablo bien en español, pero yo tengo mucho, I have like a lot of gratitude to talk with you today, para la experiencia de somos equipos, porque es una enfermedad difícil y importante, y I think we all have a lot of passion for this disease and for our patients and our families. And I'm really, really grateful for this opportunity, so thank you. No tengo muchas de disclosures, ahorita es solo una consultorio para el CRESTA en 2025. So gracias por invitarme de todo de mi equipo en los Estados Unidos. Aquí tiene, es una pointer, ¿verdad? Ajá, ok. Bueno, es el equipo en Stanford. Es un equipo chiquitos, como muchos diferentes hospitales. La mayoría de hospitales en el mundo es un equipo pequeño, ¿verdad? Aquí tiene dos enfermeras, enfermero Anthony y Denise, y ayudamos con todas las cosas de la línea, la cuidado de la línea y las dressings y todo. Tenemos dos nutrólogos, Aaron y Andrea, y posiblemente un día we could learn from each other here with your amazing department. I had an opportunity to hear about your research with blenderized feeds, and it was really inspiring. So espero que un día podamos exchange información. We don't have a dedicated social worker. I got to meet your team, and that's really cool. We have one social worker, Jason Brigel, for our whole department of GI and rehabilitation. And then tenemos dos cirujanos y una más doctora, Dr. Hurdes, Dr. Fell y Dr. Dunn. Dr. Dunn is mi mentor y Dr. Hurdes is mi partner en gastroenterólogo. So somos el equipo para rehabilitación a Stanford. So everyone says hi. No pasa. Okay, no problem. Ajá. Ok, bueno. Los objetivos para hoy es aquí. En general, yo quiero hablar con la inegalidad de esta enfermedad, porque la inegalidad es una realidad en toda parte del mundo, también en los Estados Unidos, aquí en México y la verdad en toda parte del mundo. Quiero explorar por qué hay esta inegalidad y qué es la causa de esta inigualdad y qué hacemos como un equipo en México, equipo en los Estados Unidos y en toda parte del mundo para ayudarnos con esta inigualdad. Y en general para los pediatras y también para los gastroenterólogos en training, quiero hablar un poco más de las comunes causas de insuficiencia intestinal. Y hablamos poco de diferentes emergencias también que miramos en este field. Es solo eso, ¿verdad?
Sí, next,
Okay, cool. Okay, so comenzamos con 4 casos porque es 2025 y siempre tengo preguntas que es raro. So sometimes I get calls and I'm still surprised that my partners across the country in California are missing pieces of information. So maybe we can go through these cases together and try to figure out, do we know what could be underlying all of these cases? So in the first case, this is a problem that we all see, right? And this is something we never, ever want to see. This is a man who, his photograph was in the lay press, so es una publicación in London. And what you notice here, obviously, is severe malnutrition. You can see he has no sub-Q fat, very, very significant large muscle wasting, and is really incapacitated. He has to sit down. He's unable to stand because of his malnutrition. This is a man who actually died from his malnutrition, and the article never once mentioned the underlying cause. So one of his friends described him as a rare soul of the earth, somebody who would do anything for anybody else. And the article describes that he was denied workman's benefits because he was deemed qualified to work, because he didn't have a medical diagnosis. So this is actually very, very common, where we meet children or we meet adults and they're not given a diagnosis. And this causes all kinds of problems, because if you don't have an underlying diagnosis, you can't get the right treatment. If you don't get the right treatment, you can't rehabilitate and improve your quality of life. And so this man, if you looked very carefully on that first picture, actually had a scar on his abdomen. And my best guess is that he did have chronic diarrhea underlying his severe malnutrition. And so this is a case of intestinal failure, probably secondary to some underlying GI tract disease. And this isn't rare, and so I think this is something very important for us to keep in mind, is as gastroenterologists and as people who focus on nutrition, people who focus on rehabilitation, it might be obvious to us, but it is not obvious to many, many people. Okay, the second case, we see this frequently, and we're told there's nothing we can do. And in the United States, there are 30 transplant centers that are listed on the UNOS website, but the reality is not that there are 30 active bowel transplant centers. There's only a few active bowel transplant centers that can help people with very complex abdomens. And so this is a problem for the future. If there are trainees in the audience who are interested in surgery, who are interested in gastroenterology, these 3 centers have limited training capacity, and there's no one to replace them. So I hope that as you go through this talk, you can maybe be inspired to consider intestinal failure or intestinal transplant as a career choice, because these centers are going to need people to replace them so that there can be something we can do. This is a case in 2020, right before the pandemic. There was a movie, if you Google it, it's called Live Almost Like Others. This is a movie that showed 8 different adults with intestinal failure, and they're talking about their own experience and what it's like living at home with parenteral nutrition all around the world. This is a woman who had 2 children on home TPN, and she said the TPN is not what bothers her. So for this woman, the TPN didn't bother her. Her underlying motility disorder doesn't really bother her. Going through pregnancy on TPN didn't bother her. The thing that she said that bothers her the most is her bone disease. So we think that there's a unique entity called intestinal failure-associated bone disease, and no one has figured this out since the 60s. So it's a mystery, a little bit, of why you can give all the mineral in the veins and not have any improvement in your bone health. And obviously bone health is very complicated. It's about muscle mass and physical activity and intake. But this is a problem that maybe one of our trainees in the audience might be able to solve one day. Okay, the third case is a case that I got when I was a resident. Or when I was a GI fellow, one of our residents called me and said, obstetrics keeps paging us. And I said, why is obstetrics calling GI specifically? They wanted to speak with the gastroenterologist on call. And I said, why? Usually that would go to neonatology. Are you sure they have the correct people? Why are they paging GI? And they said they want to talk to intestinal rehabilitation at 2 a.m. That's pretty unusual, right? Nobody pages us from obstetrics. So I asked the resident to get more information, and when we got more information, this is what we learned. The obstetrics team had been taking care of a 37-year-old woman with polyhydramnios. Ella recibe 10 veces con una tap amniótico y cada vez saca 1 litro de líquido afuera de la sac amniótico. So does anyone know what this could be related to? Why would a patient need 10 liters of fluid tapped from their amniotic fluid? Any guesses? So intestinal obstruction can do it, right? Certainly that's a cause of polyhydramnios. Pero no 10 litros, ¿verdad? En 7 meses. It shouldn't actually make it to term, but 10 litros is mucho, ¿verdad? What else could be causing that? So, es una causa de diarrea congenital. Es un caso de diarrea de salt wasting. So this is activation of salt transporters. The baby was dumping salt into the lumen of their bowel in utero, and obstetrics wanted us to be available with neonatology to write the TPN prescription to keep this baby from dying at birth. So es un caso de intestinal failure in utero. And so, this is what this was going on. Okay, last case. This is a case that I sort of modified, but it's similar, and I'm sure you've seen patients like this. When I was a third-year GI fellow, I got a page from an outside hospital. The center that I trained at was a referral center just like this one, so we would get phone calls from various hospitals. In this case, they wanted clearance from a GI doctor to transfer this patient to a psychiatric unit. I said, why do you need GI clearance for psychiatry? And they said the patient is suicidal and they say they have abdominal pain. I said, okay, well, why do they have abdominal pain? And long story short, we dug around a little, got some information, and this is what the film looked like. Yeah. So what do you notice about this film? Los intestinos es muy, muy dilatado, ¿verdad? It's like 10 centímetros para the small intestine, and I think all of us would be in severe, excruciating pain with dilation like this. This was a case of a boy who was essentially more or less normal with a few episodes of obstruction, a history of malrotation that was repaired in infancy, and in middle school, his bowel just sort of stopped working, had very severe dilation, and eventually developed intestinal failure because of this motility problem. So this is another case of intestinal failure due to a problem with motility, but the page came to us through psychiatry. So I show these cases because I think es la realidad para intestinal failure en 2025, ¿verdad? Mucha gente no entiende este diagnosis, pero es diferente de los algo 3 tipo de organ failure. We would never treat organ failure of the liver as yellow skin, coagulopathy, and high ammonia. We call it liver failure. And hay trasplantes aquí para eso, hay protocols, es like rápido, ¿verdad? Todo es rápido. They don't spend 2 years in the hospital with confusion about the diagnosis, right? They don't get profoundly malnourished. Same thing with heart failure. No one would say, oh, this patient has a little fatigue and edema. They just call it heart failure, right? But for some reason, for intestinal failure, we have all these other diagnoses, suicidality, polyhydramnios, low magnesium, these diagnoses that are not unifying. And I think it's because the intestine is responsible for the rest of the body. So you have multi-organ disease that does have a unifying diagnosis. So in October of 2023, which is unbelievable, right? TPN was invented in 1967. But we didn't have a diagnosis code till 2023. This is the diagnosis code for intestinal failure. So if we don't have this diagnosis code in our notes, the hospital doesn't understand how much money we're saving them, right? If you don't have this diagnosis code in your notes, your bosses and your insurance companies and your government payers don't know how much care you're providing, how you change lives. Nobody knows because you're just fixing hypomagnesemia, right? You're doing a lot more than that, so I think this is important. So I think this is where we are now. We should all help our colleagues and other hospitals and systems understand intestinal failure is defined as the inability to use the GI tract for 2 or 3 months independently, right? And I argue it's more than fluids, electrolytes, and nutrition. También es la desarrollo para los niños chiquitos y también activities of daily living para adultos, ¿verdad? So no one should look like that first patient that we saw in that first picture, ever. The 3 most common causes are short bowel syndrome, or los intestinos cortos, es like 60% de pacientes en la mayor edad de programas en el mundo. 30% más o menos es problemas con motilidad, neuropático o miopático. Y para mí yo miro like 10% pacientes con problemas con variantes genéticos, como la paciente con polyhydramnios. Y a veces cosas más raras, personas con inmunodeficiencia primario, gunshot wounds and motor vehicle accidents, tumors and some other things. But these are the most common causes, and they all have a unifying diagnosis, which is intestinal failure. This is hard, right? Ustedes mira cada día, la inequalidad es un problema con recursos y también con acceso, ¿verdad? If you have a patient in your care, you can change their lives. But if they live very far away from your center, it's hard to take care of them. Today I got to see an electronic consult. Your team here is doing consults with people all across the country, and I think that's incredible work. It's not easy to do that, to hear someone's story from far away. You can't see the patient, you can't lay hands on them, but you're doing your best. That's incredible. And this is a common problem. So in the United States, adults, especialmente para adultos, hay no programas para rehabilitación más o menos para adultos. Todos los programas es para niños pediatras, pero para adultos, a veces personas va like 1,000 miles para acceso para cuidar. And then there's some regional variation. This was published in 2022 by Dr. Mundi and Dr. Iyer. Obviously on the West Coast, the states are very far away, so the access is a lot worse than on the East Coast where people are traveling like 50 miles. It's not so bad. So let's explore together, why is this happening, right? En México y también en los Estados Unidos, ¿por qué hay mucha inequalidad? Posiblemente es una cosa que es muy raro, ¿verdad? So, no es recursos porque es una enfermedad raro. Pero yo no pienso es la caso. Yo pienso es más común de cystic fibrosis, es más común de leucemia, y leucemia recibe mucha atención y muchos recursos, ¿verdad? Y también más común de acute liver failure, y también acute liver failure tiene grandes programas para trasplante. So, la causa de inequalidad es no porque es raro, es no común como inflammatory bowel disease, pero es no raro. Okay, so es no raro, posiblemente es una algo cosa. Posiblemente es porque la prognosis is, maybe the prognosis is very, very bad, and that's why I didn't even learn about this in medical school. I didn't hear the word intestinal failure all through residency, and I finally figured it out when I was a fellow, okay? Maybe we don't have as much awareness because it's a very bad prognosis. And I don't think that has to be the case. And you have seen, I saw today a case of a child who was told they had a bad prognosis and then came here and has rehabilitated with simple interventions like mucus fistula refeeding. This is such a simple intervention that just requires TLC, right? Cuidar de los enfermeras, cuidar de los médicos y de los nutricionistas. Y todos trabajan juntos como un equipo, y la vida de este niño es totalmente diferente. 3 months ago, he could have been told he was going to die, and now he's probably going to leave the hospital without TPN and be happy and chubby, right? So I think this isn't a problem about prognosis necessarily. And we know that even in the first years in the United States when kids went home on TPN, in the 80s, out of the first group of 100, this was a 25-year retrospective study that they were looking at outcomes. When they were just learning how to do rehabilitation, they didn't even have nutrition support specialists at that time. About half of the kids came off TPN on their own, achieving independence on their own. So I think that speaks to the regenerative power of the bowel, right? And a lot of those kids were in school going home with cycled TPN, like many of your patients are going home. They were very creative, right? They taught their patients to compound their TPN in the garage. That's the story that we hear, right? We don't do that anymore. You do it in the hospital, and the patients come here and get their bags, or they have a commercial vendor. But I think this creativity, which I've seen and been so inspired by here today, is part of our history. So the problem isn't that it's rare, that has a bad prognosis. It's been around since 1967, and I saw this in your presentation earlier. Dr. Dudrick invented this when he was a surgical fellow. So if there's any trainees in the audience who think, you know, I'm just a trainee, I can't do this, that's not the case. He was a fellow when he invented TPN, and the outcomes are really unbelievable when you have appropriate nutrition support. So, si hay bien tratamientos para eso, y es no raro, ¿por qué personas morir de eso? ¿Y por qué miramos mucho sufrimiento? Posiblemente el tratamiento es difícil, ¿verdad? Maybe this is a very complicated thing. I don't think that's the case. This is our state flower from California. It's a poppy. I think of this as pretty simple. It is regenerative medicine. If you lose half your bowel cannot be expected to do 100% of the work, right? And our nutrition support specialists understand this. They create very clear programs to help that organ regrow and regain its function. And it's kind of simple, right? If you need 1,000 calories a day, you lost half your bowel, you're going to need at least 500 calories IV for that organ to regrow. And the intestine has stem cells. It can regenerate. It can achieve independence. It just needs that caloric support in the early phase after the accident. It's not hard, right? So sometimes my trainees are like, "Oh, TPN is too difficult. I don't want to join this field because it's hard." It's not that hard, right? I think ultimately the problem is this is a multi-organ disease that is sort of left behind. I call it volume-based healthcare, right? Insurance companies in the United States don't create profit from chronic complex illnesses. They make profit from very frequent short-term visits, and that is not intestinal failure. I think many people are studying the cost savings of the work that we all do, and so hopefully, I saw today even just simple interventions like blenderized tube feeds saving hundreds of dollars a day. We are a very creative field. We're a group of people who are dedicated, who can really change lives. We just have to convince others that it's cost saving. So this requires institutional support, government support, payer support, and I think some of that is not in our hands, but I think that's the cause ultimately of the inequality. So what is in our hands, right? I just talked about all these bad inequalities and really the suffering that our patients experience. Yo pienso que la cuidad de las personas con intestinos corta, it is possible to change people's lives in 6 months, right? The patient that I saw today, his life today is completely different than it was just 2 months ago, 3 months ago. So this is my style of rehabilitation, and I'd like to share it. It's by no means the correct style, okay? This is just what I do and what I hope helps get people off TPN as fast as possible. And we'll see, we're part of the International Registry of Outcomes, so we'll see if this style works or if another style works. But I will share that this is sort of our team's approach surgically and medically for the care of patients mainly with short bowel syndrome. This doesn't apply to congenital diarrhea and motility problems as much. I have 6 things that I try to do, okay? Number 1, which I think our programs share, is reconnect as soon as it's safe. So after you have an abdominal catastrophe and you have a stoma, that distal bowel and the colon needs to see food, and it needs to see effluent. If you don't reconnect, the risk that you have permanent TPN dependence increases every week. Now, I also understand where our surgeons are coming from, that you don't want to go into a frozen abdomen because that's a risk of fistula development, anastomotic dehiscence, all of these things. But I think there's a balance. So in our program, we try to get kids reconnected for good old-fashioned necrotizing enterocolitis in 8 to 12 weeks max. Sometimes as early as 6 weeks if it wasn't very necrotic or there wasn't a lot of sepsis or the baby's very well nourished and very stable, or as late as 12 weeks if we've maybe failed an attempt before. And I think this is very, very beneficial. And before you reconnect, we definitely want to convince our neonatology colleagues to help us with mucus fistula refeeding whenever possible, if there's ileum left over. So step 1 for us is reconnect as fast as you can. Number 2, in the first 6 months, especially the first 6 months for a baby under the age of 1, I try as much as possible to avoid diarrhea. And this is a hard sell, right? This is a hard sell to the hospital because they stay in the hospital for a long time. This can be a hard sell to families because they want their child to eat normally. But I think if you avoid diarrhea as much as possible in the first 6 months, that is the maximal benefit for that child to potentially come off TPN permanently. And the way I think about this is really just the bowel grows the most rapidly in that first year of life, right? So it's almost, I think of it like almost like 10 centimeters a week, right? From term to 1 year, it's 100 centimeters of growth naturally. And so every episode of diarrhea that you have in that first 3 months postoperatively is a missed opportunity for organ regeneration, right? If the baby is having more than 30 per kilo per rectum, 40, 50 per kilo per rectum, and we're blasting them with feeds, that organ can never recover and regrow. But if you are patient with the intestine at the beginning, hold back a little bit on the feeds, and I have, we can share protocols and things like that. Hold back a little bit on the feeds until the baby is demonstrating they tolerate the feeds in an acceptable amount of stool output. That is the best chance that baby has to regrow their intestine. So that's our strategy. I have colleagues who do not believe in this, okay? So again, my approach is not the right approach. I have colleagues who give full TPN calories and let them eat whatever they want. They do that a lot in Europe as well. And so we'll see what ends up with faster rehabilitation. I don't know, but I think that's one option. There are 2 different styles. So.
What's the most you tolerate?
Yeah.
In grams per weight?
In millilitros, no sé en grams, pero yeah. So para recto, I say 20 millilitros cada kilogramo para recto. For an ostomy, 30, yeah. It kind of depends, right? If the kid's liver is really bad and you need to increase the feeds and decrease TPN, then you can make a patient-by-patient decision. But essentially, I use a protocol that's stop, stay, go, okay? So if the baby has less than 10 to 20 per kilo of stool output per rectum, you need to push the feeds, and I push by 10 mLs per kilo per 12 to 24 hours, depending on the baby, depending on the neonatologist on call, depending on the nurses on the floor, depending on a lot of factors. At home, the equivalent of that is like 2 diapers a day if the parent is doing the rehab, right? Because they're not measuring it. I have one family that measures it, but most of my families are not measuring it, yeah. And then to stay, if it's between 20 to 30 per rectum or 30 to 40 per ostomy, I just stay the course for 1 to 2 days and then try again. And then if it's 40 to 50 per kilo per ostomy or 30 to 40 per rectum, then I decrease it. And sometimes it just depends on the baby and the quality of the stool and the growth pattern. If the baby is gaining weight, you may not actually have to decrease it. Right? That implies that either your calories are very juicy IV or the baby is absorbing more than we think. But if that output is high, sometimes I'll pause for 12 hours and then try again at yesterday's rate, or sometimes I'll pause for 24 hours. Very rarely will I pause for 48 hours. And that's a situation where the baby is like dehydrated, acidotic, losing weight, and looks bad. Then we'll really take a step back. But that's my protocol in like a nutshell, and I can send it out by email too. As part of this feeding protocol, I try to balance slow drip feeding with oral feeds. We don't want kids to be orally averse, but if you have the opportunity to have a nasogastric tube or a G tube, I split that 10 mLs per kilo in half, so 5 mLs per kilo overnight, drip, 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 slow to stimulate the mucosa to regrow their villi. And then 3 oral feeds during the day and advance in that manner. And I think this prevents the situation where you have a very hungry baby that's binging and dumping, because that is hard on all of us. No one wants to see a hungry, starving baby losing weight and dumping and then binge eating by mouth. So this is the strategy that we use. Sometimes as they get older, we'll do 4 or 5 oral feeds and 12-hour drip feeds. It just kind of depends. Dilated enteropathy is an interesting entity. We just wrote a paper on what we think this is. There's not good definitions, and so we need more centers to be evaluating. But we've all seen patients where the proximal bowel, especially when the bowel was very short, gets very dilated. And then it doesn't work. It's sort of game over after that, unless you get a tapering to sort of narrow it down into a tube instead of a big balloon. I think this 18-3 feeding might help because it avoids having a big bolus of food go into the small bowel all at once. Now, again, I don't have data to support that, but maybe we could try to figure this out, because once the bowel dilates, it's very hard to get kids off TPN. Then it becomes very permanent. And then I think you all know very well about how to protect the liver. I think of this as sort of TPN heavy. If the patient is reconnected and they have enterohepatic circulation, it's okay to give some extra calories like we were learning about in your protocols. I think that's very important. But if they're not reconnected or they're ultra short with no hope of feeding, then in that case, sometimes we do use calorie restriction to try to help protect the liver from liver failure. So those are my 6 strategies in a nutshell. I don't know that they're perfect outcomes, but this is the data that we have so far. So we're part of this International Intestinal Failure Registry. It's a prospective registry. It's many centers around the world. In red is the registry outcomes, and in blue, it's our outcomes. At 1 year old, 30% of our patients are able to come off TPN. And at 5 years old, 100% came, or at 3 years, 100% came off TPN. This is very biased, okay? This is only 30 patients, and I don't think this reflects the experience of all 200 of our patients. We certainly have people who are not able to wean TPN, but at least in this prospective registry, using this style as much as we can, with a majority of patients having short bowel syndrome these are our outcomes. So we'll see what happens. I'll give you an update in 2 years. Okay, I want to pause and see if there's any questions, and then I thought we could talk a little about line care and a little bit about some innovations in necrotizing enterocolitis. Buenos días.
When you mentioned about the rehab goals to avoid diarrhea, what other strategies do you use besides the nutritional part? You mentioned that you did an advance and such to prevent that.
Great question. So I would say in the first 6 months, it's all nutrition support. I very rarely use loperamide in the first 6 months because I want to teach the parents what diarrhea looks like, right? Because sometimes it's their first baby. They don't know like the difference between normal stool. Sometimes my own team doesn't know the difference between diarrhea and normal stooling. So in that first 6 months, especially right after a surgery or reconnection, I don't use any meds. It's only this intestinal rehab protocol where we call it the push and pull of rehabilitation, right? Advance feeds if there's not enough stool, hold feeds if there's just the right amount of stool, and peel back if there's too much. After 1 year, right, when at that point the natural growth is slower, you're trying to improve quality of life, maybe get them out of the hospital, that kind of thing, then we use loperamide and we use teduglutide, which I hope Takeda will bring here one day. I don't understand why they can't. It seems silly, but yes, I think that's the answer. Yeah, so I try not to use, but all the interventions that we target, in general, the younger the baby and the more aggressive you are, the better. So I'll do medications by 1 year, the feeding protocol from 0 to 12 months. If the baby is very dilated, I think a tapering procedure can be maximally beneficial. I had a baby, which I think, yo pienso es una milagro, ¿verdad? So ella tiene jejunolatresia con 23 centímetros de small intestine y she had a full colon, but her bowel was very dilated at birth, right? It was like 6 to 1. This surgeon, who she's not part of our regular team, but she's a colorectal surgeon. She was the surgeon on call. On day of life 1, she reconnected the baby and did a tapering procedure. So she took the dilated jejunum and made it a tube instead of a big balloon. And that baby is currently almost off TPN. It's crazy. And she's not on Gattex because the mom refused. Mom didn't want injections for teduglutide. And otherwise, she's not on loperamide. She's not on anything. So I think that this speaks to the power of the control we have as teams, right? We don't have access to teduglutide here, but that's okay. You can control their diarrhea, right? We don't have access to other types of resources, and our patients have limited abilities, but we can offer tapering and mucus fistula refeeding. These things make a huge difference. So yeah, I hope that kind of answers that question. Yeah. Okay. I bring up this picture, although it's very hard to see. Very rarely you can see a fibrin sheath on a chest x-ray. So I bring that up to say if you're in a bind, sometimes you can see it. And this diagram on the left shows different types of problems with clots at the end of the line. Almost everybody develops fibrin sheath at some point, but either with the flow of the TPN or heparin, if you're using it, it should dissolve, so it kind of comes and goes. What becomes a problem is when the vein gets very irritated, either from removing a lot of lines or it becomes irregular in shape. It sounds like here we're mainly replacing over a guide wire, so you can avoid a lot of these complications, but at some centers, the line is completely removed and put into a new site. So when you do that, you introduce variability in the flow of the vein, and there's a much higher risk of venous thrombosis. So I think as much as possible, if you are not able to repair a line, this guide wire exchange is very, very important. We say same vessel, same site as much as possible. And this is really just to prevent thrombosis. I've done different things to screen. I used to do yearly ultrasound, and then I stopped. And then I tried MR, and then I stopped because it requires anesthesia. So I don't know what the right way to screen for this is and to give someone anticoagulation. But there is also some evidence that the prevention of clot is protective against infection also. So I trained at a center, we use no heparin, and then I work at a center where everyone has heparin, and I think maybe using heparin is helpful, but I don't have, again, good data for that. Okay, let's talk about the dressing. I know you have a whole team that takes care of your central lines. This picture here, this picture down here with the stoma is what we never want to see, right? The central line should never be hanging out on the bag. This was a picture of a boy who was running through one of the hospitals that I worked at when I was training, running through the halls with his central line on his stoma and no cap. So that's a big no-no. So we always say, and what we teach various units, lines up, tubes down, right? The line should never be in the diaper. I've seen some nurses in different units use the diaper to hold the line, and that should never, never happen, right, ever. So lines up, tubes down. The two pictures on the left, I think, are better dressings to avoid a break and to keep it from getting infected. So what we do is we try, this picture on the bottom with the blue square, I think is a more ideal dressing. We try to make a loop, so a tension loop, so in case the baby pulls the line when they're running, there's some give and it doesn't just come out of the chest or the dressing. And also the fat part of the line should be underneath the tape. Because if you look at the picture up on the top, you can see how the fat, skinny junction is at the border of the tape. That is going to rip 100%. There is no baby who can have a line like that won't rip. I had a patient in the hospital. The parent never had a single tear, okay? And then the baby got admitted to the hospital, and various people who were taking care of that line didn't understand how to dress the line. That kid had 6 line repairs for tears just because of this fat, skinny junction. So I think this is like an easy thing that we can all do to reduce the prevalence of line breakage. And then that picture, again, is just don't put your line on your stoma. Do you use purple lines here? The purple power lines? Yeah. 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 I'm not sure how I feel about them either. I don't like them, to be honest. I don't like them. They are less likely to break.
But the industry is pushing a lot to change to use them.
We use them with the Securelab.
Yeah.
And they didn't work that because they're too skinny. They will just push into the skin.
Yeah. I've just learned about this Secure Lock, and like I'm a little afraid of them, like if they're going to get tunnel infections. But I do think the industry is pushing these power lines, and I don't love them. I think in a case where you're not able to repair, it might be something to think about because they don't break as much, but they point straight down, and they cause a lot of tunnel infections, and I think catheter precipitation.
In Mexico, there are no repair kits.
Yeah. So I think it's like a balance of risks. It might be something to consider. They don't break as much. They're stiffer lines, but I think then the risk is then you end up with this. So I think you've probably all seen these, but these are pictures, and these are courtesy of Dr. Wendell, who's a line care expert, and one of my mentors, one of our nurse mentors, Lori Rayan. These are all examples of tunnel infections. Sometimes tunnel infections are hard to see because it's a very avascular space, and so they don't get as red and nasty as and inflamed as you would think they would. But if you milk the pus down, sometimes you can see the pus come out. You can see in some of these pictures the underlying cause of the tunnel infection was pressure on the skin. So if you don't rotate the direction of the loop, or if there's sutures that are sitting there irritating and scratching the skin, or if the baby gets very hot and sweaty when it's hot outside, that's, I think, the highest risk for tunnel infection. what we've done in the summer is switched from the plastic dressing to gauze dressings because I think it airs out a little better and prevents the maceration of the tunnel, but it's also a risk of like entry into the tunnel. So it's, again, a balance of risks. But these are some photos of tunnel infections. And then the stitches. So I don't know what your process is about stitches, but the stitches drive me crazy. I want all of my stitches out by 12 to 16 weeks after placement. Usually the line should be tunneled by then, but if not, it can cause these granulomas and tunnel infections. The risk there is, of course, that the baby can pull the line out, but I don't know what you do for your stitches.
Like 2 weeks and that's it.
Okay, thank you. I'm going to tell my team that 12 weeks is too conservative. They get mad at me when I tell them to cut out the stitches at 12 weeks, so I'll tell them 2 weeks is better.
4 weeks.
4 weeks, 2 to 4 weeks, okay. But you need to prevent, I mean, these are preventable infections from irritation from the sutures. Okay, the top 3, what do you see and what do you think is going on in the top 3?
The cough is being
Yeah, exactly. So I point this out because sometimes it can look like a granuloma and it can get mistaken for a granuloma, which is just friction irritation from the line. But you have to be very careful. Sometimes it's not just a granuloma, especially the line that's heavy and pointing down. Sometimes it's cuff extrusion and that line has to be exchanged. It's not sterile anymore.
Have you identified which patients
Spit it out.
spit it out?
I think it's when they're sweaty. So it's the kids who get a lot of, like especially in the summer, when they get a lot of under the dressing irritation, and then we're trying to preserve supply, so they're only changing it once a week. I think what happens is it gets macerated, and then the friction starts to create tunnel inflammation. There's maybe a subset that are just allergic to the material, but I think the kids who spit it out are those kids. Now, I don't have enough like volume to say changing the dressing helps more or not. I don't know, but yeah.
The really skinny ones
Mm.
will also like
With no fat.
Yeah, because they have very less fat.
Actually, that's probably true because there's nothing to scar down and tunnel. Yeah, that makes
I have
sense.
a couple of patients that they expel all the lines.
Are they immunocompromised?
Not that we're
No.
Not that we're aware of.
Yeah, I don't know. It's interesting, right?
like this.
Yeah. Yeah, this bottom one is just contact dermatitis with impetigo. So this can be treated with topical creams and doesn't need line exchange. So, okay, this is an example of an aneurysm. Has anyone had patients with these? Yeah,
It's on the catheter, right?
yeah,
Yeah, there's a thing in St. Louis.
It
Yeah.
happens every time after a year.
it does. So I think the cause of this is if the line becomes sluggish, especially if you're not using heparin flush or bicarbonate flush, which we kind of talked about. I think what happens is the caregiver or the nurse starts putting pressure on the line, or they use a syringe that's too small. Would never use a small syringe, always use a big syringe on the line. Because when you put the pressure, then the plastic just balloons and then it has to be repaired or replaced. It's game over. 20 mLs, yeah, that's better. I've seen, like in an ER, I saw a nurse try to use a 3 ml syringe, and she just fractured the line. The line just broke. There's blood everywhere. It was terrible. Don't do that. Okay. This is what the repair kits look like. I hope one day we can maybe write a letter. We'll write a letter together and try to get some repair kits because it's like life-changing. I had a patient who had 16 line repairs and a line for 10 years, the same central line. So there's no upper limit to line repair. The only limitation is the distance from the chest. You can't repair it if it's more like, 4 centimeters, because it's just too hard to put together. But we'll write a letter together. Maybe we'll make it happen. Okay. I want to talk briefly in the last few minutes about innovations in necrotizing enterocolitis. So I went to medical school over 20 years ago, and in that time, there have been 0 medicines for necrotizing enterocolitis. We all do the same thing. We watch the belly, we look for ileus, we examine the baby, we get ultrasound and x-ray, and then what do? We use antibiotics, right? we use antibiotics after the pathology has already occurred, right? So we think the pathology is downregulation of these TLR4 receptors, and then that exacerbates the multi-organ vascular hit that baby has received. So this is where we're doing. The TLR4 gets downregulated, and then you have no more nitric oxide to the epithelium, and so that perpetuates the mucosal injury essentially from ischemia, and then you get pneumatosis and all these findings. So this is what we've been doing for decades, right? But I think that there is some hope. There are surgical innovations and medical innovations that are happening. So maybe one day we'll all be out of business. We can all retire from this challenging field, right? This is a phase 1 clinical trial that my mentor is doing. He's invented a device. It's a little spring, and I'll show you some pictures of what that looks like. He introduces this spring surgically with a trocar, with an enterotomy on that left-sided picture. This was an adult with 100 centimeters of small bowel. 2 patients were done like this on the adult side, one with colon in continuity, the other without. And then there's these plication sutures. And essentially, just like jaw or femur extraction, the spring stretches and pulls the intestine to get bigger. So in pictures, it looks like this. You can see in the top left corner, the spring is compressed, and over time it grows, and then eventually gets pooped out. So this patient came off TPN. Whether or not it was the spring, we don't know, but it was just a phase 1 trial for safety. At least the patient didn't perforate or have any complications. We did this in one baby. Yeah, it looks like this. That's what the device looks like and what the spring looks like on the end of the device. So this device was placed in 1 centimeter of ileum. This baby had 30 centimeters of jejunum in continuity with colon for volvulus, but he had 1 centimeter of ileum on the side that was preserved, just in the hope that we could stretch it. And so we placed the spring in that little tiny piece of intestine. We did stretch it from 1 to 5 centimeters, which is a big deal when we're talking about ileum, right? The ileum is magic. It can do the job of the jejunum. It secretes GLP-2. So anything we can do to preserve ileum is very important. So this baby, I tried to get the spring out he did not poop it out. I tried to get it with colonoscopy, and it was horrible. It was the worst colonoscopy I've ever done, and it had to be surgically removed. But it was a very small, tight space, and I just couldn't exert pressure to get the spring out. So anyway, we'll see what the clinical trial shows on this. Preclinical studies show that this improves villus crypt hypertrophy and that it doesn't cause significant scar in the muscle layer. You can see the control is on the left, and on the right, the trichrome is more robust, but it doesn't have like a focal scar or anything like that. So that's that. In terms of medical innovations, there is a drug that's being developed. The Hackham lab at Johns Hopkins made this compound. I don't know what he's going to call this medicine, and they're planning phase 1 clinical trials. It's a TLR4 agonist, so hoping to prevent that pneumatosis so that we don't have to be in business much longer, hopefully. We'll see. And then the last innovation I wanted to talk about, I think, is very innovative, very creative, and important for us to talk through. This is a procedure called remote ischemic conditioning. And the idea, again, is that you have these premature babies, they have some systemic compromise in their perfusion. And that affects the gut when they have necrotizing enterocolitis, especially the early grade 1 or grade 2 neck. The hope is that by causing brief constriction of the arm, right, that the baby will then shower the body with these pro-vasodilatory factors. So the cuff is constricted and released in cycles. And in doing so, the baby is supposed to be able to recover this necrotizing enterocolitis phenotype. So this is very cool and very simple. It's just a blood pressure cuff. They did a phase 1 clinical trial in the fall, just making sure that the cuff didn't cause hand ischemia, and it was safe in very small infants. So we'll see what their phase 2 studies look like. But okay, that is all I have. I thank you again for inviting me and for teaching me. I really, really appreciate all of your time.
Preguntas para la doctora. Estefania is a first-year fellow.
Oh, mucho gusto.
Hi, nice to meet you. I have one question. When you talked about between the balance in oral and enteral food, I saw a 3-18,
Yeah.
but I didn't understand what was that meaning.
Yeah, so in our rehab protocol, we feed 10 mLs per kilo. We try per day, but sometimes it's every other day or every 2 days, just depends on the baby and the team. What I try to do is I split that between 3 oral feeds and 18 hours of drip feeds at night. And the drip feeds are with a tube, usually, G-tube or a nasogastric tube. And I think in doing that, you achieve that balance of slow feeding so the baby can absorb the food while simultaneously preventing hunger and preserving oral stimulation. And if the baby doesn't have diarrhea, you can make a decision to increase the volume of the oral feeds preferentially. But I think most children with less than 50 centimeters, I think they benefit from tube feeding. It's a hard sell sometimes to convince a surgeon or a family to put a tube or a nasal tube when you have 50 centimeters of bowel. It's a hard sell, but what I've found is it shortens the amount of time on TPN because all the feeds are not by mouth. Because when all the feeds are by mouth, they just binge and they dump and then they dilate if they're ultra short. So that's that 3 oral feeds, 18-hour drip. When they get older, closer to 1 year, I bring it down to 12 hours so that the baby can run and play and achieve all their developmental milestones. Yeah.
Thank you.
¿Más preguntas? Ahí está. She's a fellow for nutrition.
Awesome.
Well, basically on the enteral feeds or on that strategy that you use, is there a specific type of formula that you use or any criteria to decide which formula to use, or how do you?
Yeah, that's a great question. I'd love to hear what you do here too. Preferentially, we use breast milk. Even though it's not, broken down, because there are growth factors, there's probiotics, and the ratio of fat is just so much higher, it's absorbed much better. Even in kids with no ileum, I think breast milk, if it's available, is very, very important. The protein load is lower, it's just tolerated better, and I think it results in much less diarrhea. If there's no mother's milk, we try to use donor breast milk, but that's hard. No insurance companies cover donor breast milk. And then if the patient has resources, they'll pay for it, or they'll get it sometimes like from a friend or a neighbor. But we can't provide that outpatient. In the hospital, we can provide breast milk, donor breast milk from like the milk bank. If there's no breast milk, I don't know what the right answer is. So I have colleagues who swear they should just have regular term formula. I have other colleagues who swear they should have elemental. So I just picked the middle. I picked the hydrolyzed. I like the lower osmolarity, like Nutramigen, or when we used to have Peptamen for older kids. And then I'll dilute it. Sometimes even for a kid over 1, we'll bring it down to 20 calories. If they can't tolerate 30 and they get diarrhea, we'll dilute it. So it's not clear. But I do try to introduce complementary foods around the normal time when the baby has demonstrated, safe swallowing and development, 4 to 6 months. And then I just limit fruit and lactose. That's it. And sweets. I say no cake till you're older, like 3-4 years old. But yeah.
Thank you.
We actually use full term and milk, first stage. Then we go to whatever with hydrolyzed, but with a little bit of lactose, low lactose. That's what we did in our protocol. And after that, if it's not well tolerated, we will go for amino acids, or stuff like that.
Yeah.
And we are trying to start earlier with complementary feeding here, because we have tortilla. That's our big game changer.
So tortilla de maíz, yo pienso es like mucha beneficios. It is very, very well tolerated. None of my patients have problems with tortilla de maíz. I don't know why, like flour tortillas, some kids, they like start throwing up and they have diarrhea, but I haven't seen a lot of problems with corn tortillas. Maybe it's just the processing. I don't know. You probably know much better than I do.
It's magic. It has calcium.
Yeah.
No added sugar and calcium.
Yes, and also like one, as I said, it should not have added sugar. Also because like the cornstarch is like you don't really get the absorption as fast as it would be with the wheat. So they also like tolerate this part, and it has also fiber. So it would be like a combination, and also like calcium. So it would be also like playing a part with the electrolytes that we are just giving to themselves. Also something I would like to ask, but also address, is like, as you already heard, is like we don't always have like breast milk. So sometimes we use like the formula and we complement it with 1 or 2 types of lipids. So it could be like short change lipids, so they can be absorbed in a fastest way. But also we started like putting like long change lipids, so they could be like stimulate the entire site. So we were just trying also to feed like, don't go to one side only, but just have the benefits of both. So we can just mimic a little bit like the breast milk.
Yeah, I love that. We need to experiment more with that. We used to have short chain fatty acids like available in the hospital and in pharmacies, and then a few years ago it like disappeared. None of us can find it. It's very hard to find. So, because there was a product, and I'll come borrow some from you. But I don't know, that's a great idea with the longer chain, because I think we forget about that. But breast milk has those, so probably needs that stimulation. Yeah.
¿Más preguntas?
Thank you so much.
Thank you so much for coming all the way here, and a big round of applause for her. Un aplauso muy grande. Thank you very much. Pues muchas gracias a todos por su asistencia aquí, los que estén en su casa y tengan preguntas, igual viene mi correo y se los podemos hacer llegar a la doctora. Muchas gracias. Oh, thank you. It was a long day. So you missed the Frida Kahlo